Good morning, everybody. I will try to do this review of the literature. It's a presentation I've done at the Microbe Congress, and I've treated several topics, including Clostridium difficile infection, Escherichia infection, and emerging issues in complement to a previous topic done by Andy Lee. And I had a look at all these journals during the preparation of my presentation. But I also browsed a couple of blogs, including Hair Controversy blog and Reflection in IPC blog. Let's start with Clostridium difficile infection and with the concept of asymptomatic carriage as a reservoir for the potential transmission of C. diff in hospitals. This first study, published by Longton in JAMA Internal Medicine, implemented a strategy of search and isolate to prevent the spread of C. diff by putting a screening at the emergency unit. They screened more than 7,000 patients, and they found that there was asymptomatic carriage in 5% of them, 368 during the intervention period. All these patients were isolated, and when we look at the trends in terms of C. diff infection, we can see that the trend was decreasing from 7 cases to 3 cases per 10,000 patient days between the pre-intervention and the intervention period, which was significant in terms of comparison. When we focus on the intervention period, we can see in the orange line the level of C. diff infection in Quebec Sutherland Institute, which is the institute of the study group, and the blue line is the incidence in the area of Quebec in other institutions, and they also compare this to at the province scale. And they've seen, when they've done the time series analysis, they estimated the level of CDI without the intervention, so the theoretical number of infection, as they've seen that there was a difference between the intervention and the expected number of cases of around 60% of prevented CDI. There was also potential confounder acknowledged by author, like the increase of anti-hygiene compliance. There was also a change in antibiotic and PPI consumption, and they finished by concluding that it was a cost-benefit strategy. So in conclusion to this study, they screened 121 patients at the emergency unit, leading to 6 asymptomatic carrier, and they isolated all these one to prevent one Clostridium difficile infection. As a new concept, as a new strategy, a lot of discussion have been engaged after that, including this one with the pro-con debates in the Reflection in IPC blog, and they also in this blog tried to do a survey to see what was the feeling of people, and it's led to a majority of people in disfavor of the implementation of this strategy in their hospitals. What about the transmissibility of C. diff if we're stopping contact precaution for a patient with CDI, accepted 027, 078, and incontinent patient? It has been done by Widmer in CID 2017 with 750 cases at the beginning with CDI toxigenic strain, and 6 of all these infections were documented to be probable transmission according to the pathway, so meaning to be in contact with another CDI patient previously, and it has been confirmed as a transmission by new genome sequencing for only 2 patients. It means that stopping contact precaution do not lead to a huge impact in terms of transmission, with only 1 to 2 cases per year explained by this cross-transmission in hospitals. We need to be careful with this study because it was in a particular setting with a high level of anti-hygiene compliance, low level of antibiotic consumption, and CDI incidence. Now, what about improving on the environment disinfection for C. diff? This study, published by Curtis Donskey team in ICHE this year, had the objective to have a look at the impact of an improved environmental disinfection on the incidence of C. diff. So they implemented a very strong indication process based on several markers, including fluorescent marker, to see if there was a removal of them during the cleaning, to check the cleanliness, and a high-touch surface culture to feed people back about all this data. And they succeed in the improvement in the increase in the removal of fluoride marker by 60 to 80%. They also succeed in decreasing the burden of C. diff contamination in room from 30 to 3%. But when they were comparing the group of 7 hospitals with the intervention in comparison to the group of 8 hospitals without, there was no reduction in healthcare-associated C. diff infection incidence, which is a pretty pity because we're strongly focusing on environmental disinfection when we are dealing with C. diff, and it seems to not be to having a huge impact. What about antibiotic stewardship for C. diff? 2 studies, major studies published in Lancet Infectious Disease, assessing what is the reason of a decrease of C. diff based on the exploration of the impact of national campaign. The first one was in Scotland, based on the reduction of 4 types of the use of 4 types of antibiotics as a 4C strategy with fluoroquinolones, conoxiclav, clendan, and cephalosporin. It was also added of a strong national campaign for the improvement of hand hygiene and cleaning. And they've seen that after the implementation of this intervention at the national scale, there was a decrease, a reduction of the number of infections by 70% in hospital and a decrease by about 50% in the community. But there was no independent effect of the infection control measure, probably because hand hygiene campaigns were based on alcohol and swab use. And there was a strong impact association for the carbapenem use on the CDI. There was also a concept of threshold, meaning that if you are crossing a threshold, you have more risk of antibiotic use. You have more risk to get CDI, and it has to be tailored according to the setting. This more or less same study, same method, what is explaining a decrease of CDI in England following national campaign introduced in 2007. Do the reduction in use of antibiotics is correlated with the decrease of C. diff? We can answer yes. For fluoroquinolones, yes. For cephalosporin, with a cross correlation, perfect cross correlation for quinolones and cephalosporin. Is the improvement of infection control activities inferred in the occurrence of secondary case? When we are splitting susceptible strain and resistant strain to fluoroquinolone, we can clearly see a difference, and all these campaigns had an impact on resistant strain and not on susceptible. It probably means that infection control is not avoiding all type of infection, but fluoroquinolone is avoiding resistant strain infection. So the impact is probably in favor of the antibiotic stewardship in comparison to the IPC activities. So the reduction in fluoroquinolone use led to a decrease in the selection of fluoroquinolone-resistant C. diff and a decrease of C. diff infections. All this paper led to discussion. Most of them were fed by Mark Bonten with the correspondence published in Lancet by his team, and there were several questions listed, among which the advantage between resistant and susceptible strain, the duration of carriage, does it impact the transmission if there is a difference in duration of carriage in the community in hospital setting. All this question listed could be part of a PhD if you are interested. So in summary of all these major papers from Lancet CID, all are concluding that antibiotic stewardship probably is the most cost-benefit intervention to prevent C. diff infection. It also prevents other things, so it's a good point to focus on all these measures. Let's approach healthcare-associated infection now. With this study, major study published in PLOS-Med last year by Cassini, trying to assess the burden of healthcare-associated infection at the European scale, they took all the data collected during a prevalence survey in 2012, and they assessed the number of cases of healthcare-associated infection to be around 2.6 million per year, with a daily of 0.6 million years lived with disabilities and 2 million years of life lost due to healthcare infection and 90,000 attributable deaths. It's an important study in terms of politics because it can give data to politics and to make them taking decision for resources. But the most scientific interesting part of this paper is this slide with 60% of attributable deaths to healthcare-associated pneumonia and BSI. And when we are comparing the incidence and the burden, we can see that there is clearly a discrepancy between the incidence of healthcare-associated infection and the burden they are creating. SSI have got a high incidence but a low burden. UTI is the same, and BSI are raising from incidence to burden, the same for healthcare-associated pneumonia. And when we are only focusing on the burden of healthcare-associated pneumonia, it's representing more than 1/3 of all lower respiratory tract infection burden annually. What about catheter-associated infections now? With this study, major study published in Lancet, comparing different type of catheter to prevent BSI. It's a randomized control trial in a children population of pediatric ICUs in 15 English hospitals, and they compare antibiotic CVC to standard CVC and heparin CVC with the BSI, and they've clearly seen that there was a decrease of the BSI, the rate of BSI in the antibiotic CVC arm in comparison to standard CVC and in comparison to heparin CVC. This was true for the crude assessment and for the adjusted model with this Cox regression analysis with a nasal ratio clearly showing that there is a prevention of the time to first BSI when we are putting antibiotic impregnated catheter in comparison to standard CVC. So in conclusion to this study, antibiotic impregnation is decreasing the BSI rate by 60%, which is pretty high, versus standard, and 59% versus heparin. Now, what about individual elements of bundles to prevent catheter line-associated bloodstream infection? This study had a look at this with a population of ICU adults, 1,000 people, and they splitted bundles, and they had to look at the impact if we are using only one element, and if we are using more than one element. And the conclusion of this paper is to say that even if you are using one element, you can prevent CLABSI significantly. But you need to implement it properly and with a high level of compliance. And if you're doing this, the compliance has to be more than 75%. So, and the more you have elements, the more your bundle is working. So it's an interesting paper, methodologic paper, but it's important to say that even if you are using only one bundle, you need to focus on the compliance. Now, a major study published in New England Journal of Medicine 2013 with the objective to see if at the national scale, a national comprehensive campaign to reduce QOTI can have an impact on the number of infections. So this intervention was implemented in a large scale, 1,000 units in US. With an intervention based on 5 elements. The first one was daily assessment of the presence of catheter urinary tract, an alternative to urinary catheter, the asymptomatic technique to feed people back with rates to try and identify gap, and with the possibility for settings to adapt this intervention to their local hospital, and with an implementation strategy with strong sponsorship at the national scale, a lot of guidance, a lot of tools, and an emphasis on socio-adaptative factors. So they had a look at infection and the number of catheter inserted. Here you can see the study timeline. And when we have a look at outcomes, we can clearly see that there is a significant decrease of QOTI during this study from 2.4 to 2.05 QOTI per 1,000 catheter a day, and it was also true for the catheter use from 20 to 90%. And when they were analyzing in detail quality rate and catheter use according to the settings, there was no impact in ICU. Non-ICU were more benefiting from the intervention than ICU settings, probably due to the fact that in ICU there is a low margin of progression because patients need close monitoring of urine outputs, they need catheter for routine culturing and so on. What about surgical site infection now? A lot of new guidelines have been published, as you probably know, from WHO, from CDC, from a lot of societies. All these guidelines were based on a huge effort of meta-analysis, 27 for WHO. I will not present all this meta-analysis. I will only focus on several points. The points were the working group cut. And the first point is the decolonization of patients with carrying Staphylococcus aureus, which has to be done, whatever the type of procedure now. The glucose control for diabetic and non-diabetic patients, the use of alcohol antiseptic with chlorhexidine for screen prep, the 80% FiO2 intraoperatively and during the follow-up of the patient after the procedure 2 to 6 hours after, the end of the plastic adhesive incise drop, the consideration of the irrigation of the wound after before closure with povidone iodine. You need also to consider 3000 coated suture to prevent infection, end of laminar airflow even for orthopedic surgery, to stop antibiotic prophylaxis once the incision is closed, whatever the type of surgery. So as they cut, there was controversy behind. After that, with the 80% FiO2 problem, for three reasons. The first one is that between the publication and the assessment and all the work done for this recommendation and the publications, there was a lot of new literature showing that there was no impact on SSI risk of FiO2. It's in practice not possible to implement this. And there is also a problem of arm of hyperexia and a concern around that. So FiO2 is not so clear-cut right now. The decolonization, Mark Bonten said in a post that it's probably better to treat all based on several previous studies like Wong, like Vassamber and so on, than screening and then decolonize. But it has to be added of monitoring of myopirosin and chlorhexidine resistance to reconsider the strategy if there is emerging resistance. Now, do we need to infuse patients with antimicrobial stewardship just before the incision, or can we do earlier? It's a randomized controlled trial done in Switzerland in orthopedic and vascular surgery, comparing the 0 to 3 minutes before incision to the 30 to 70 minutes. And what they've seen in a huge cohort of patients, 5,000 patients, they've seen that there was no impact in terms of surgical site infection if you are treating the antibiotic prophylaxis in the early stage in comparison to the late stage, whatever the type of surgery. And they recommended to not change recommendations, and they are keeping in their hospital the recommendation of 30 minutes before the incision. Very short, this slide coming from the air controversy, Mike Edmond, comparing the skull cap with the Buffon cap. It's a controversy between surgeon and nurses societies right now in US, and they've seen that with this before and after study that there was no change in surgical site infection when you are switching from skull cap to Buffon cap, but we need to be careful with this study because there was no adjustment according to confounding factors. So it was just to say something around closing in the operating room. To finish with SSI, this study on surgical site infection surveillance, adding a picture, a photo of the wound can help to assess the SSI. It's clearly yes. If you are giving SSI cases and non-SSI cases to a blinded assessor, you can see that adding a picture will change his choice from a wrong statement to a true statement at the end, improving the reliability of SSI diagnosis. And authors have taken the opportunity to develop a smartphone app, which is also an opportunity to engage patients in the surveillance of their wounds and to understand what is important to have a look in the post-operative period. So what about healthcare-associated infection, healthcare-associated pneumonia now, with only one paper, this paper by Krompas in JAMA Internal Medicine, splitting as it has been done, as I presented previously with another study, splitted a bundle of measures to have a look at the impact of each element. And they found pretty surprising results. The oral care with chlorhexidine is increasing the ventilator mortality. So prophylaxis stress ulcer is increasing the risk of VAP. All other factors are decreasing the time to extubation alive. So the conclusion of this paper was to say that we probably need to revise our classic ventilator bundle. Do we need to exclude oral care from protocols according to this result? And we don't really know yet, but one major output is that stress ulcer prophylaxis has to be taken into account only for patients at risk. So now just a couple of topics for emerging issues. The first one, as you probably know, is Mycobacterium chimeray infections in cardiothoracic surgery from 2007 to 2015, with this UK team addressing the problem at the national scale by investigating all potential cases. So they took the culture positive with Mycobacterium chimeray, 7,000 culture, and they had a look at all possible cases. And they found that there was 19 probable cases during the study period at the national scale, with an increase of the incidence from 2010 to 2013. And when they analyzed all clinical characteristics, it was mainly mitral and aortic valve replacement, with a median time to infection of around 1 year, meaning that we need to do a long follow-up of patients, and a rate of death of 50%. The environmental contamination were also interesting. 35 3T sarin units, intercolor units were analyzed, and half of them were positive with Mycobacterium chimeray. And there was also an analysis of the circulating water. When it was used, there was an increase of the particle count around the intercolor unit, and there was also a disruption in the flow of the circulating water in this unit, probably the reason for the excretion of particle around the unit. And as it has been discussed by Dan Diekema in a post, we are probably underestimating the problem. 108 cases have been unofficially counted by Dan, but there is no mandatory reporting, no global registry, and we probably need to be careful about this. And to be honest, probably a lot of hospitals are not investigating all cases. So what's the reason of this? This study is an experimental study. The author put a 3T unit in an operating room, as they had a look with a smoking test where was going the smoke when we were putting on the unit, and they've seen that once the intercolor unit was off, there was no particles, when it was rotating on towards the table, there was an increase of particle on the table, and when it was on the way, this particle count was decreasing. It means that rotating the unit can have an impact. The orientation of the unit can have an impact on the particle, on the potential contamination during surgeries. And it was also true with the distance 3 meters to 5 meters. This study in New England Journal of Medicine is probably the major one. During these studies, they've done whole genome sequencing on strains coming from different countries, but the same intercolor unit, still the 3T serine. And they found with whole genome sequencing that there was no possibility to distinguish the whole genome level, the code genome of all these strains, meaning that there is a probable common source, and the common source is probably the manufacturer. And to confirm this, they took a strain coming from the northern hemisphere, and there was still a DNA conservation. So there is a potential global dissemination of contaminated medical devices, and it's a potential problem at the international scale. So how can we fix this problem? The first step is to determine the risk. Do you have a 3T serine in your wall? And did you use it the last 6 years? If it is yes, you need to investigate. The risk mitigation, get this unit out of the operating room. Then you have to identify and notify all potential cases. And it's probably the major part of the job, but it's important, I think, to spend time on this. To finish this presentation, the last topic is Candida auris, with this study in CID 2017, assessing from 5 countries whole genome, by whole genome sequencing several isolates of Candida auris, and they found that there was a very huge burden of this infection with 60% of BSI, 50% of patients died as well, 40% were resistant to at least 2 antifungal classes, and there was unique class by geographical region when they were analyzed with new genome sequences, all these trends. So it's a new problem, potentially due to antifungal selection pressure, and there was in-hospital transmission at the origin, probably at the origin of this outbreak. And this art has also been done by US by the CDC very recently. It was last month with the 77 US cases, showing that it was very severe infection, and there was also colonized person around the index cases, needing contact precautions for colonized patients. And there was also a role played by the environment in terms of dissemination of the bug. And the Royal Brompton Hospital faced one case, and they've done a very strict surgeon isolate strategy. You will see this at the end, after the end of this presentation, if you download the slides. Are we prepared to that? Probably not. This survey done by Andreas Voss this month, showing that only 30% of institutions have done a warning about Candida auris, and 50% of UK respondents believe that their lab were correctly diagnosing Candida auris. So there is a potential problem. We're not prepared to that, and we need to probably to keep in mind that it's a potential public health problem. Thank you for your attention.